We got to bring the overhead in. Okay, if you recall from last time, I was talking about the English and French 100-year war, and hopefully you were listening to the entirety of the whole idea of the importance of strength of the digits of the finger, and I talked a little bit about the strength of the middle finger and the importance of that in terms of pulling the arrow back and releasing the string, and that was from this information right here, and what we have in regard to that, lost my laser pointer, doggone it, is looking at what I was pointing out is a difference between male and female strength. As you can see up here, it's pretty typical in terms of just about everything that we look at, from lung capacity to strength, cross-sectional area of the muscles, and so on. And we also see this in fingertip strength and so on. And then we have the major, and of course, the major and the minor aspects of that. And hopefully there we go. Major and minor, so that's your dominant hand, right, and the non-dominant hand that we're looking at, and the differences between male and female. I will not hold you responsible for memorizing this kind of information, but I will hold you responsible for the concepts of the differences in terms of strength between the dominant hand and the non-dominant hand, and differences between male and females, and strength of the digits that we see right here. And digit 1 is your thumb. Okay, this is digit 2, 3, 4, and 5. Okay, so just note how those play out. So average grip strength is 4 to 5 times greater than a pinch strength. So that's why we always go for the power grip like this, as opposed to the precision grip. Remember, you saw those grips I showed you earlier. Lots of different ones, finger press and so on. The only ones I really want you to really focus in on are precision, which is most of you are using right now for your pencils and pens. And then the power grip is if you grab onto a bat or pick up luggage or something. So this is work I did actually with Barbara Silverstein back when she was at the University of Michigan. We were students together, and she went out and did this research. Kind of dating myself a little bit. Tom Armstrong was my mentor there. But what Barbara found out is that the relationship between low repetition and low force, and all the way up to high repetition and high force, and these are defined as high repetition, cycle times of less than 30 seconds, and performed greater than 50% of idle work, and jobs that were low repetition were greater than 30 seconds. But then in terms of force, we're looking at things about 12.7 kilograms, or around 25 pounds of force. So anything that was involved in a cycle time in terms of a work repetition, let's say as you had experienced on the first exam, let's say a frequency of a lift, if you were doing that twice a minute, for example, and let's say that box weighed 25 pounds in each time, that would be considered high repetition, high force. Okay? Below that, low repetition, low force. So you have to divide that. And if you look at the tendinitis and carpal tunnel syndrome up here, and this kind of made her, somewhat world famous, I guess, when she came out with this, is that she looked at odds ratios. Odds ratios, as you know, anything above 1 is a greater risk, right, for a particular injury. And she found that if you had high repetition and high force, you were nearly 30 times higher, the odds are 30 times higher of getting tendinitis, inflammation of the tendons, or over here, an odds ratio of over 14 times higher for carpal tunnel syndrome. So that was a very significant finding, and so it goes back to the 7 risk factors that I talked about, where they're not additive, but there's synergy. And so you don't say, we'll say high repetition, high force, awkward postures. This would be additive toward an outcome of an odds ratio. It's really high force times high repetition times awkward posture, that kind of thing, that gives you these odds ratios that you see right here, because we're only looking at a repetition force issue and something that's almost 30 times greater. See, so it's not additive, it's multiplicative, and that's an important concept for you to know. So when we get into static loading, one of the important concepts here, and you may see this as a quiz question, is when we're in a resting state, just as you are right now, you see blood needed and blood flow are low. So all of you are very comfortably positioned, just as you are, arms down by your side. There's no one sitting there with their arms hanging over their head like this, right? Just, this is what I want to do because it's comfortable. You know it's not comfortable. Why? Because the blood needed and the blood flow, when you're dynamic, when it says dynamic, you contract and you relax. You contract and you relax. However, in static efforts, as you see over here, the blood needed and the blood flow are opposite. You need more blood, but the blood's not getting to the muscle. Why? Because just in the simple thing of raising your arms up, if you're just, extend your arms out, go ahead and extend your arms out in front of you right here. Feel with your opposite arm the deltoid. Just feel that deltoid and squeeze it, and you feel it's contracted, right? It's contracted and strong, feels good. What's happening is that because it's contracted, the blood getting to it is being reduced because this is contracted. So you're clamping down on that muscle. The blood and the oxygen want to get in there, but it's not happening. As soon as you relax it, go ahead and drop your arm. Now feel your muscle. Nice and relaxed. See, that blood flow is going in there very easily. This is the concept of the other risk factor of static loading. And that's one of the reasons why anytime we do work like this over a period of time, we are doing, it may not look like we're doing work, but the muscles are working in order for us to be in this position. But it's not getting the oxygen, meaning not getting the blood flow. And that's an important concept. So when you go out and you look at certain jobs, what the eye is trained to do is look for motion. But the other thing that you should do is look for things that people are in static positions for a long period of time. And you can see this anywhere. Some of you, who did the barista stuff at Starbucks? Anybody here? Okay. Did you see anything there that might lend itself to the argument that I'm making right now about static loading? Give an example. The baristas, right, holding their arms out, doing this thing with the coffee and patting it down, this kind of stuff. Look at their arms, and it doesn't see it, but they're out like this the whole time. There's nothing in there that's designed right where it would allow them to get closer to the counter, bring their arms close to their sides, and be able to do this work. The whole thing like this is done all day long. Not to mention the noise problem that they have in there, right? So mark my words, I don't know this happening, but I would say within 10 years, you'll see Starbucks with multiple lawsuits with hearing loss among people like you that work in these places, and second, musculoskeletal injury issues. Why? Because of poor design, and most of it's because of the workspace. And maybe that's one of the reasons why they get really antsy when you come around and take a look at what they do. Static loading is a big deal. So when we break down cumulative trauma disorders, the neck and back, the upper limbs, the lower limbs, we can see that when we focus on neck and shoulders and the spine, the hands, wrists, elbows, feet, knees, and hips, that we have these various outcomes. There's the cervical syndrome, tendonitis, chronic low back pain, de Quervain's disease for the hands, trigger finger, Raynaud's syndrome, that's vibration related, carpal tunnel syndrome, we talked about that last week, tendonitis, tenosynovitis. We get into the elbows, we have tennis elbow and golfer's elbow and miner's elbow. Remember, tennis elbow is on the lateral side of the elbow. This is because of the backhand, right? And I showed you that insertion point in the elbow. And golfer's elbow is the medial aspects, right, swinging through with the golfers. And it's the same thing with the miner's elbow on the medial aspects of the elbow. Then we get into the lower limbs. A lot of people don't focus on this too much, but as more and more jobs get into standing all day and so on, we have tendonitis of the lower limbs, tenosynovitis. This tends to occur especially in the joints around the knees and so on. Ligament injuries and bursitis. This happens also around the knees. Ligament kinds of injuries tend to happen around the ankles and so on. And a ligament versus a tendon, you know the difference, right? And the difference is bone to bone versus muscle to bone. That's right. Ligament versus tendon. Thanks. So when we get into awkward postures in hands and wrists, turning the palm of the hand upwards, supination, right? This kind of rotation. Twisting of the wrist, bending the wrist dorsally, extending the palm, flexion. So flexion, extension. This is one of the reasons why I wanted you to know motion and position. Shoulders, raising the arms above shoulder level. Actually, I want you to correct that and The newest literature coming out, raising the arms above heart level, okay? Heart level, right here. So your shoulders are up here, and this is, and visually it's easy to see, but in terms of true ergonomic principles, you don't want to get it above heart level, and the reason for that is pooling of the blood, right? Putting much more cardiovascular load on the heart when you raise your arms above heart level, right? So if you're at shoulder level, you're still putting a good cardiovascular load on that heart. So let's correct that. Raising arms above heart level, okay? Holding the elbows away from the body, of course, out like this. The neck and back, bending the neck downward. This is neck flexion, right? Forward flexion. Holding the chin forward. It's like pushing the chin out, craning the neck when you're trying to look at something, and bending the back forward to reach an object. For example, bending like this forward to reach, and as I mentioned to you, making it an asymmetric load with basic forward flexion, lateral rotation. Back injuries then, we have lumbar strain, chronic lumbar strain over time, herniated disc by sudden movements, twisting, strong pulling forces, compression fractures, muscle spasms, scoliosis, that's abnormal curvature of the spine, unstable vertebrae, kyphosis, this is backward curvature of the thoracic spine. So know the difference between scoliosis and kyphosis. I think I've got some pictures here to show you that. And then hyperlordosis this is excessive development of a forward curvature of the lumbar spine, basically going down where that you have an excess curve in the back, and it makes it look like the buttocks are protruding. So this is your scoliosis. This is basically looking in this dimension. You're looking straight at me. So the scoliosis, you're seeing the curve out to one side. In this case, the example is going out to the left side. And the cervical, this is now looking at it in this plane right here. What we see is that in kyphosis, it's more of a humpback. You see a lot of older professors with this kind of thing going on, just basically walking around like this, see that? Because they're not forced to retire, they can stay here until they die. And part of the problem is obviously, they're in that position for long periods of time, bone development and so on, absorption. So we get kyphosis, and then hyperlordosis down here is where you see the excessive bending down by the lumbar area. And the disc, as I mentioned, the pressure that comes down on the disc in terms of the forces caused by the excessive backward bending and pressure coming down here, you can actually erode the bone right here with excessive use there, or have an acute traumatic injury. My wife had this on a snowmobile, where basically they hit a bump when we went up flying. When she came down, she didn't stabilize herself and came down and crushed one of her vertebrae. Fortunately, she had some numbness and tingling in her spine. She injured her spinal cord a little bit, but the good news is that most of that recovered, but to this day she still has weakness in that area from that acute compound compression. So common causes of back injuries that we see are sudden or jerky movements, extreme twisting, pivoting, lifting objects too far away from the body, that horizontal issue that I keep bringing up, lifting with the back flexed over. So basically now you're really extending out that horizontal. Using weak back muscles instead of the leg muscles, which are stronger. So, and this is one of the things that comes up quite a bit with people, with trainers that come in and say, lift with your legs and not your back. The problem is if you're lifting a lot, right, with your legs, what happens? Your legs get fatigued, and now you're saying, you know what, I'm not going to do that because my legs are fatigued because they're the largest muscles in your body. I'm just going to use my back, and I'm just going to hang on the ligaments, right? Well, the problem is now you really are putting a lot of forces on the back, but what you're doing is you're saving yourself cardiovascularly because the legs no longer have to absorb all that energy by squatting and lifting in the proper way. So you basically trade one for the other. It's usually the legs that will give out first before the ligaments start giving out on you in terms of the other kind of lift. So something you have to watch out for. And to me, it's a bit of a challenge talking to trainers, because the trainers will get out there and show you one of the cleanest lifts you've ever seen. You know, they'll squat, they'll go right down, they'll go right straight up, they'll squat, and they'll do it one more time like that. And you're sitting back looking at them, you're doing this thing 8 hours a day, and you say, you know what, go out there and do that for at least 2 hours straight. Do my job, and let's see how good this kind of thing looks. They never last. They never take that challenge on because it's a great principle, but it's not exercised. Reaching above the shoulders, obviously we talked about that a little bit. Awkward workstation design, we'll pick up on that a little bit later, but low workstations, high workstations, working away from the body, the baristas I'm talking about, and because of the design of the shelves. Back is unsupported, lumbar support, and then poor postures in sitting and standing. Good examples are a humpback or rounded shoulders, basically, as I talked about a little bit earlier, bent over, working on a desk for a long period of time, years. Flattened or sway back, holding the chin forward, slumped posture in sitting, vertical vibrations such as those experienced by truck and bus drivers. And these are, there are two kinds of vibration right here that I want you to write down: whole body and segmental. Okay? Very important here to understand the two. So a lot of times for truck drivers and so on, the whole body becomes an issue. It's not only the bouncing up and down, it's also back and forth, right, in terms of lurching, with the loads in the truck. And then there is segmental. And segmental really deals with the individual limbs. So segmental vibration might be a chipping tool or something of that nature that would vibrate a chainsaw and so on. That would be more of an example of a segmental vibration issue. There are obviously the acute kinds of episodes such as accidents. A bad mattress. I don't know if many of you have rental places and so on. You moved in, there's the bed, there's the mattress, and you're feeling this mattress is a pretty bad mattress, right? Maybe it doesn't have a box spring, or the box spring is worn out, or you feel like you're just kind of falling into the center of it or something like that. Do yourself a favor and say, Mom and Dad, if you're going to give me anything for Christmas, give me a new mattress. And a good mattress. They'll thank them for it, because number one, you need a lot more sleep than you realize, and number two, when you do sleep, you want to have a good night's sleep. A poor mattress will not allow your muscles to totally relax and give you that good night's sleep. Why? Because you're going to be fighting it because you're not sleeping comfortably on that particular mattress. Not to mention all the other chickasauruses and crazy stuff that's maybe left there from other people. So like, that kind of. So anyways, it's something to think about. And then the big belly, right? Large abdomen, weak muscles. You particularly see that among men of my age, where the belly starts to hang out a little bit more and so on. And what that is basically abdominal fat on the inside being pushed out. And number two is just weak muscles, because they haven't really had to use them for much of anything as a result of that. The issue isn't so much with the abdomen, which you can see. The issue becomes with the weak back, right? The weak muscles in the back as a result of that. So that can lead to bad backs as well. With the hands, it's our median nerve right here. It's just kind of an illustration. It's much bigger than what it really is. But it basically shows you across this way is your transverse ligament. So, Thanksgiving's coming up next month, but the example I like to use a lot is just like your belt. After you have a big dinner, you like to loosen up that belt and kind of let that gut hang a little bit because you've eaten too much and so on. The same kind of principle they use here to release pressure in the wrist by basically cutting that transverse ligament, loosening things up, allowing less pressure along the median nerve and the surrounding blood vessels, tendons, and so on, and it gives you some temporary relief. The problem is that the outcomes a lot of times are 50-50 in terms of surgery, because for a lot of people, depending upon the makeup of scar tissue and so on, this can form scar tissue back over that and press down on it and make it worse than it was originally, or the same as what they had, or in some cases they do get some relief. The problem is that you're treating the symptoms and not the cause. The cause was by something they did, the type of work they were doing, and that's what you have to attack. The surgeons love to do this stuff because they get a lot of money for it and so on, and insurance companies will pay for it. The problem is that in many instances, again, about 50% of the cases, they don't see any improvement, or in some cases it gets worse. So just like back surgery, same kind of thing. So in terms of vibration white finger, the only thing I want you to know on this is a difference when we're looking at our stages for the vibration white finger. So if we go from 0, 0, this is no tingling, numbness, or blanching of fingers. Work and social interference, no complaints here. And I like to say no report of symptoms. No report of symptoms rather than no complaints. Because complaints like, stop your yapping or whining about something. It sort of like puts the burden back on the worker. And I think if the worker's saying, I'm not reporting any symptoms, it comes off much better than if you're saying, well, the person's not complaining about something, because it suggests it's a psychological issue rather than anything else. Then it goes all the way up to 04 from 0, 0. And the other end of the spectrum, as you can see here, extensive blanching, basically, the blanching meaning vasoconstriction. So basically the fingers look a little whiter, not the good pink color that you want to see, or where it has good blood flow in most fingers. And this is, during summer, in winter. Winter especially, when you have the cold interacting with the exposure to the vibration-related disorders. And then occupation usually change because of severity and sign. And the reason they do that is if you're holding a tool that basically you have such weakness in the hand because of the neurologic impact with the hand that you can't hold onto the tool. You really can't feel it or operate the tool, and you're out of business. So my pre-dental students, it may not seem like this is a big deal, but holding those tools in a certain position over a period of time, they're vibrating and so on and so forth. The posture, the force, and the precision that you have to use is static loading over time. And I can tell you that I've dealt with a lot of dentists in the public health service, actually in this case the Indian Health Service, especially out west, is that one after another would come in, they couldn't use their hands anymore, and the only thing they could do is become administrators. Because when you lose these in your profession, you're done. You're really done. So it's something to think about. And I think for almost all of you, you have to use your hands. Yes? Proper techniques are supposed to be taught. The tools are supposed to be there. But a lot of times you can't always use the proper technique based upon the patient. So let's say you get into pediatric dentistry and so on. Those kids are not going to be listening to you, and you're going to get in there and do the best you can as quick as you can, right, to get these jobs done. And a lot of times it's turnover and so on. And what happens is that, I don't care, and I've been involved with laparoscopic surgeons, brain surgeons, to dentists, to oral maxillofacial surgeons and so on. You're so focused on what it is that you're doing that a lot of times you don't even realize you're sacrificing your body to get the job done. And then you're on to the next patient. Why? Because it's just a mind over matter thing. Everything, every ounce of thought and concentrations on what you're doing, and at the end of the day, you sacrifice your body and you don't realize it. Good question. So when we get into Raynaud's disease and phenomenon, there are two definitions for this. In terms of disease, and this is a vibration-related disorder. Symptoms due to other underlying diseases, no. But with a phenomenon, see, they don't fully understand it, it's yes. Laboratory evaluations such as blood count, so on, looking at antibodies. Here's your connection now with the molecular, right? It's normal, but in a phenomena, it's abnormal. When you look at the assessment of the blood and lymph vessels, normally no structural changes, and here you see structural changes, trophic changes such as necrosis and so on, uncommon in Raynaud's disease and common in Raynaud's phenomenon. So the difference is someone may be exhibiting exactly the same symptoms, but when you do the medical workups, the outcomes are different regarding the disease versus the phenomenon. It's just not fully understood. So, tests that can be done, you'll be tested on this because I expect you to know the difference between Tunnell's test and the Fallon's test. And the Tunnell's test, basically you're tapping the median nerve of the wrist, and what you're doing, if it's compressed, what's going to happen is that you're going to have tingling in one or more of the fingers. And which fingers are they going to be? The index finger, right? The middle finger, part of the ring finger, and the thumb, right? That's where you're going to feel that tingling in there, and that might indicate that you could be afflicted with carpal tunnel syndrome. The Fallon's test, this test, you're asked to put the back of your hands together and flex your wrist and hold it for 1 minute. So, and you develop tingling there. So Tunnell's, the way I try to remember it, Tunnell's is like tapping. So basically, go ahead and hold your hand up right there. Take your 2 fingers right there and just touch right in the center, right here at the base of the palm, right in the wrist. And you might feel just a little bit of tingling right there, and it's normal. But if you really had carpal tunnel, you would really start to see that those shock waves go up into the fingers. The other way to do it, right here, this is Fallon's. This is the Fallon's test right here. You hold that for a minute, and what you're doing is you're restricting the flow right around because you have a high degree of flexion. Hold that for a minute, and then release, and then see if you've got tingling and numbness in the hand. If you do, after a minute, that indicates that you may have some symptoms to that. Does it mean you have it? No, but does it mean you may be on the way to getting that? It's a very strong possibility, and then you have to do further neurologic tests to prove that out. So know the difference between Tunnel's and Fallon's. Preventive measures for cumulative trauma disorders. Number 1 is engineering controls. 2nd is administrative controls. 3rd, personal protective equipment. Right here, I can tell you, if you have a good back, do not, I repeat, do not wear back belts. Don't wear them. Because what's going to happen is they restrict motion, especially for the ladies. With the hips, they tend to push the back belts up, become very uncomfortable in the midsection. For the guys, it restricts their range of motion in terms of moving. And if you go back some years, you would go into a place like Menards or Walmart's or Sam's and whatnot, and everybody was wearing a back belt. And then they say, well, you don't want people to be seeing those back belts, so wear it underneath your clothing, right? And now it would get hot and restricted and so on. And now what they say is that go ahead and wear it, but keep it loose. But when you go to lift something, tighten it up. Where this thinking comes from is that, hey, weightlifters use back belts, so that should be good for anyone lifting anything of any weight, right? It's like a box. The difference is weightlifters, when you look at them, especially lifting, say, barbells from here, look at how it's done. It's up close to the body, right? The horizontal is left. Flip it up like this. And in order to stabilize the spine, you've got the back belt there, and then you push up, right? And you're going for usually a maximum lift. And you're not doing this all day long. You're just doing it, to achieve that particular lift. You're lifting a box, a totally different thing is going on, right? So this is not a barbell, as you can see, but it can be big and bulky. And now I'm getting around it, and there's no way that I can lift this like this. So what I have to do is I have to open my stance, come down on this, and lift it like this. And look at that horizontal. I'm way out here like this. If I have a back belt on, right, now it's going to restrict my range of motion, and it's going to compromise my ability to get down, get this thing closer to my body, and bring it up like this. See the difference? So it's like trying to use one principle for one thing and relate it to another, and it doesn't work because the mechanics are totally different. Completely different. So at the top, engineering controls, job rotation, job redesign, for example, workplace redesign, tool redesign, automation, all these things come into play. Administrative controls, rotating the workers, work schedules, and so on come into play. Personal protective equipment, if there are a couple of things that I would say, okay, fine. One would be knee pads, so put those down. Knee pads are okay, makes sense in terms of high forces. So, okay. And armbands. And this is on the forearm, right? When I talked about my last lecture, right around here, in order to provide further stability across the muscles for the insertion point in the olecranon. So that works. Back belts don't. So whenever if I'm going to ask you this question, it'll be on the exam, and I won't get funny about the question. If you have a bad back and the physician says, I need you to wear a back belt, I'm okay with that. They call it a lordotic device, by the way, because that's the reason they can charge more for it. They call it a fancy name. But it's basically a back belt. That's stabilizing the spine until it gets better, right? You've injured yourself. But if you don't have a bad back, wearing it to prevent an injury actually is contraindicated. So don't do that to yourself. So prevention of CTDs, job redesign, obviously, to avoid the repetitive task, enlarge the task requiring different movements, different muscle groups, and so on. Have work cycles longer than 30 seconds, right? You saw that earlier in terms of that being the tipping point for high repetition, less than 30 seconds, high force, more than 25 pounds. Minimize pinch grips, right? You want to use power grips in here. Excessive forces are to be avoided. Avoid vibration, whole body and segmental whole body. Get the sheets or the seats that are vibration attenuated so that you bounce, and it goes also forward, up and down, as well as back and forth. So you see a lot of the bus drivers on the better buses now. The seats are going up and down with the road. Segmental vibration, it's isolated at the motor housing. And then automate where you can. So here's a couple of examples. We're going to go through these real quick, then we'll do our quiz. And I just want to challenge you a little bit. This is in our lab right here, and redesign correct working posture by adjusting the workstation bench height. And these can be motorized up or down right here. You can see we have neck flexion. That's not too bad. But if you're doing this all day long, you're going to have some tension in the neck, right? Tension neck syndrome, so on, setting up from this. However, and you can see this taller worker here, well, in this case, it's a student, but not a good position to be in because it's too low. And here, we've adjusted it up, and you can see the posture, a little bit of neck flexion, which is okay, but not too much forward, but you can see nice up and down versus this, because you will feel that load as the day goes on. And so here is the way it is, and we can adjust this up a little bit higher. Nice, straight posture, and that position is fine all day because you're not loading the back, that static loading. So when we look at elimination of extended reaches, avoiding work surfaces causing friction or rubbing on your body parts, in particular, this is anything that where your hips come up to it. The ladies have more problems with this than the males do, and the reason for that is that for the women, the hips, in terms of the iliac crest, flares out a little bit more. So any kind of hip contact here over a period of time, unless it's padded, becomes very irritating. So what happens, without really knowing it, the ladies will step back an inch or two, and now they end up working the rest of the day like this. Whereas if you pad this, everybody can get up closer to it and be able to do this work. Also, need for a toe box right here, right, to get your feet underneath. That makes a difference as well. Extensive wrist deviation. We went through that in terms. Remember the finger and the grip. We went through that. Hands and forearms should be able to move straight out from the body instead of maneuvering. Elbows close to the body is always important. Having bends that tilt to you rather than reaching up and over and in, having it tilt toward you so you can pull it straight out. Adjusting work surfaces for the body, bringing the work to you easier. Provide armrest. You don't have them on your chairs right here, but there was a condition one time when I worked. It was actually it was a health insurance company, and the safety officer was a larger person, and they didn't like the idea of armrest. And I think part of it was a personal thing because of the size. And I made the argument that armrests really do help in terms of taking load off the shoulders and off the trapezius and so on. And I demonstrated that and showed data to that effect. And it was only after more workers came in, I said, just get a couple of chairs and try it out and see if you like it. And I said, remember that if you buy a better chair, these armrests adjust in and out and up and down, right, in the better chairs. And sure enough, that saved the day and made it much, much better. So armrests do help. Store parts or containers designed, situated within workers' reach so they don't have to step out of their zone. Administrative control, revise those work rest schedules, rotate the workers, do the training. The point that was pointed out a little bit earlier. Training does help, but a lot of times when you get into it, you're in the moment, totally in the zone, you forget about all that stuff, and now you're focused on getting it done, right? And you want to do it, you want to do the right job. And of course, early communication of symptoms is key. You don't want to wait until you have a full-blown problem with the body. You want to report symptoms when you can. Prevention then, good work practices, aligning your body straight up and down, elbows close to the body, good habits using whole hand grips, avoiding pinch grips, adjusting the height of the work surface, using the right tools. And here's a good one. I'm going to test you on this. Females, the diameter of a cylinder in terms of a power grip, 1 inch on average. For males, 1.5 inches. Why? Because we have the bigger hands, right? So if the males use the 1 inch, they can still have a power grip on it, but what happens is that the digits overlap with each other too much, and they can't get the full power grip. For the ladies, the hands basically are too big, and now they can't wrap the fingers around and get the full power and leverage that they want because of the hand size. Handle lengths, a little bit bigger right here for the males, about 5 inches. The females about 4 inches. Again, same idea, hand size. You also want to account for gloves. If you're working with gloves, make it a little bit larger. Cushion handles obviously help. Tools in good repair, sharpener blades, and so on. And then this is the idea of rotation. See these how it's going like this: 1, 2, 3, 4. With worker 1, 8 to 10 machining. Then they move to stocking. Then they move to hammering. Then they go to welding. So that's an idea of work rotation. Personal protective equipment. Okay, gloves are okay, but you have to make sure they're good fitting gloves. They should fit properly and be flexible. Finger cots can be used in order to take away the trauma to the fingertips if you're pressing clips and so on. Fingerless gloves are fine in terms of taking off the blunt forces on the palm, but giving you the digital manipulation that you'd want with the fingers. Back supports are only help when the person has an injured back and it's prescribed by a qualified physician. That's what I was talking about earlier, this whole back belt thing. Be really leery of that. Knee pads, okay. As I mentioned, if you're going to get knee pads, get good knee pads. Shipbuilding, carpet layers, construction, or even just work around the house. I mean, these days when I'm crawling around, it's always nice to have those knee pads. Wrist splints, this is another big no-no. Don't even think about it. When I see people working with wrist splints, it drives me crazy, especially the secretaries and so on. They come in and they have these wrist splints on, and I said, what's going on? She said, well, the doctor said I've got carpal tunnel or I got tendonitis, and this is supposed to help it. I said, he does realize that you're fighting that wrist splint the whole time trying to do your job. It's your job causing the problem, and the wrist splint is going to exacerbate it because now you're fighting it. When do you wear the wrist splint? You wear it at night. Write this down. You wear it at night to keep your hands from going into the fetal position, right? Basically flexing those hands and wrists when you sleep, and they keep it straight. And a lot of times people wake up with the symptoms at night, not so much during the day. So you have to be very careful of that. So wrist splints at night, fine when you're sleeping. During the day, you shouldn't be wearing them because you're fighting the task. Really, that physician is only looking at you and the symptoms and saying, here, wear these, without really inquiring as to what it is you're doing that causes the problem. And in that case, he might want to say, or she might want to say, let's look at some rotation, maybe get away from that typing task and so on and so forth. And maybe some of you have experienced that a little bit when you're really pressing for a paper or an exam, right? You're really pushing yourself and you feel your hands are starting to hurt in your fingers. That's when you're really pushing yourself to the limits of what your body can do. Okay, finally through CTDs. Thank you again for reminding me to do that.